Now we move ahead, and our next speaker is from Lahore. He is pediatric neurologist, and he will talk on when to start anti-epileptic drug. Professor Dr. Tipu Sultan. I really thankful to him to join from Lahore, and he will deliver his talk on when to start anti-epileptic drug in pediatric or children. Dr. Tipu.
Thank you very much, Dr. Malik, for giving me the opportunity to speak on this very important topic on perhaps one of the most important day in terms of epilepsy advocacy. I will start with this first slide and showing the Institute of Child Health, which was a picture was taken many years back. Many of things which has already been discussed, I will not go into the details. However, focus of my talk would be initiation of anti-epileptic drugs in general, but specifically in children. Wondering why I'm not able to change my slides.
Sir, देखें ये क्या?
IT, can you please look into the matter? Slide change नहीं हो पा रही.
अच्छा सर, स्लाइड जो है वो जहां से चल रही हैं सर, आपके लैपटॉप से
आपको इनको एडमिन राइट्स देने पड़ेंगे. आप इनको एडमिन राइट दे दें तो वो हो जाएगी.
आप चेंज हो रही है, आप चेंज हो रही है.
ठीक है, हो गई. Thank you. So this is the University of Child Health Sciences. Our institute has recently been elevated to the University of Child Health Sciences, and this is perhaps one of the first ever child health university globally. And we are located on the ground floor of this new block. And this picture was in fact taken during one of the International Epilepsy Day being celebrated in our department, and the department is decorated with the purple color balloons along with toys and a few more stuff. So probably initial few slides would be a bit of repetition about the epilepsy. It's one of the commonest neurological disorder, and perhaps more common in children as well. I would like to spend a couple of minutes on this very important slides in terms of epilepsy etiology, because nowadays globally, not only in adolescents but also in children, there is a huge concept of prevention. We should spend more energy, more resources into the prevention. And if we look into the resource limited country, whether it's India, Pakistan, or elsewhere, the major contribution of epilepsy is primarily dependent upon those factors which are actually preventable. You can see in this slide hypoxic ischemic encephalopathy or neonatal or infections in children, and the genetics. Whether a genetic is ultimately led to some neurometabolic disorder or neurogenetic disorder or simple malformation of the brain, which may ultimately end up with intellectual disability along with epilepsy. So I think in countries like Pakistan, India, or other resource limited country, our focus should be on the prevention of epilepsy as well. So these are the new classification of the ILAD depending upon for the general pediatrician or for the students as a simple version, and this is the relatively more comprehensive version. Why this is important? Because a correct diagnosis of epilepsy actually led to correct initiation of anti-epileptic drugs. For instance, if you treat epilepsy syndrome like West syndrome with phenobarbital or phenytoin sodium, you might not be able to cure infantile spasm, though initial response may be a little reduction in seizure frequency, little reduction in the severity of the spasm, but per se, phenytoin or phenobarbital might not be a good option for the management of infantile spasm in children with West syndrome. So for that matter, correct diagnosis, correct classification, putting these children into the correct classification is really important. this slide, which gives more insight into the epilepsy etiology, classification, and the comorbid condition, is really the crux of my talk in terms of the management initiation. One has to be clear about the seizure type, followed by its etiology, as I mentioned in the previous couple of slides, then the epilepsy type, and ultimately epilepsy syndrome. And one should always look into the comorbid association with these epilepsy syndromes and epilepsy types, because practically over the past 2.5 decades, we have seen a lot of autism, behavioral challenges, ADHD, and other psychological issues in children with epilepsy. So by definition, epilepsy syndrome is the more important in children, particularly in early infancy and in neonatal age group, to be specifically diagnosed, classified, and ultimately for the correct initiation of anti-epileptic drug. So it's always based on the seizure type, its onset, its neurological finding, etiology, and EEG features. For example, if you look into the genetics of epilepsy syndromes, the one gene may be responsible for as simple as hemiplegic migraine, febrile seizure plus, on to the other extremes, Dravet syndrome. We go more into the details of genetics in the coming slides. So this is the importance of actually classifying children with epilepsy, with seizure, into a specific epilepsy syndrome. So as I mentioned in the initial slides, correct diagnosis is the hallmark of the ultimately successful treatment. So I would put the diagnosis of epilepsy into 3 stages. First, you should always establish whether we are dealing with a child with epilepsy or it may be a simple movement disorder. Then one should always try to classify epilepsy according to the ILA classification, or then, if possible, into a epilepsy specific syndrome. And to the utmost important, one should always try to find out the cause. But the good thing is, and the easy thing, maybe cost-effective thing, is that diagnosis is clinical. One should always take a detailed history and always follow retrospectively into the events which are ultimately end up into a seizure. So the most important point for the junior colleagues, for the residents, for the house physician, is to look into a detailed history, followed by a clinical examination. There are many neurocutaneous syndromes which are ultimately led to generalized seizure, focal seizures, for example, neurofibromatosis, Sturge-Weber syndrome, and tuberous sclerosis. So a detailed clinical examination is, again, after history, is most important point. These are some of the clinical findings in children with neurocutaneous syndromes. If we sum up the role of investigations, these days, many newer investigations are available, which include not only radiology, but also metabolic investigations, immune-mediated investigation, which are ultimately end up with many new exciting diagnosis. And last but not the least is the genetics. So I would not support genetics in every child, but whenever it is possible and whenever it is clear about the origin of epilepsy is genetic, one may pursue for the investigation of genes. Radiology is generally available everywhere, even in developing countries. So one can have CT scan if not possible, specifically MRI, but generally gold standard for the investigation, particularly in children, is MRI, 1.5 Tesla, to look into calcification, to look into some malformations of the brain, for example, mesial temporal sclerosis, and many of the malformations of the brain. EEG is, of course, really important, not only to classify epilepsy syndromes, but also for the prognosis and subsequently discontinuation of the anti-epileptic drugs. These are some of the common genes. Generally, one may find if genetic studies, whole exome sequencings are available in the centers. Diagnosis, a differential diagnosis is really important to classify epilepsy, epilepsy syndrome, and all clinical condition which mimics epilepsy. For example, syncopal disorders, migraine, transient ischemic attacks, movement disorders, sleep disorders like cataplexy, narcolepsy, and many of the metabolic disorders like hypoglycemia, hypocalcemia. For residents, for the trainees, it's really important to look and focus or maybe remember these points, because all these points are actually supporting underlying epileptic attack in children. And let's come to the main focus, main topic assigned to me by the organizer is the management of epilepsy. So generally, standard of care or recommendation is treat 2 or more seizures. But of course, there are few exceptions. Once you encounter a child with status epilepticus, then one should not wait for the second status. If EEG positive, supporting juvenile myoclonic epilepsy, if neurological examination is abnormal, like in cerebral palsy, if imaging is abnormal, or if clinically there is regression of milestone, then the initiation of anti-epileptic drugs might not wait for the second seizure or status. Here are the options, whether it's in developing countries, resource-limiting countries, or elsewhere, we have nowadays. Anti-epileptic drugs, vagal nerve stimulation, surgery, and ketogenic diet. Luckily, 70 to 80% children are nicely responded to anti-epileptic drugs, which is the main area we'll discuss in the coming slides. However, vagal nerve stimulation, epilepsy surgery, and keto is now available in many of the bigger centers, including our own hospital institute. So before putting any child or adult with anti-epileptic drugs, one should always consider all these points. And the last point is the cost. Because it's not the case like in many infections where one may take a drug for 10, 20 days. It's a matter of a couple of years. So cost really matters, particularly in these challenging, economically challenging days globally. If we go into the history of anti-epileptic drugs, in the past 2 decades, there is a rapid influx of anti-epileptic drugs with very limited side effects. However, cost is little high, so one may choose one best possible drug according to in the index patient. But the principle would remain same. It's go slow and go low, which means one should start with one appropriately chosen anti-epileptic drug, build it to its maximum level, maximum therapeutic level, maximum allowed level to terminate seizure, to control seizure. Either you one may reach to that point, or one may face another challenge of side effects of that particular drug. So first drug, slowly build control, and if it's partial control, then one may add another drug. If it's full control, then one should maintain that particular drug for at least 2 to 3 years. And if there is no control, then addition of another drug and slow tapering of the previous one. That should be the main principle of the management in children and even in adults. One should always consider all these points in selection of anti-epileptic drugs, like I mentioned in previous slides, but few more in case of children. And one important point is quality of life, learning disorders, systemic problems. Look at this young child who is obviously look little chubby. So selection of valproate sodium for maybe generalized tonic-clonic seizure in a well-thrived, well-built chubby child may end up with little more kilos after 2 to 3 years. Or selection of phenytoin sodium in young adult girl may end up with hirsutism or maybe gingival hyperplasia. So it's not always control of seizures. One should always give some importance to quality of life, or maybe phenobarbital may end up with some behavioral disorders or learning disorders. So it's always individual child, individual patient. One should look into the underlying mechanism of anti-epileptic drugs at cellular level. This is a brief list of anti-epileptic drugs available in Pakistan, and I'm sure around Asian countries as well. On the right sides, in the newer ones, which are available at a reasonably well priced, and some of them are a bit expensive. And in the left side, it's the older version of anti-epileptic drugs. And like paraldehyde is more or less now an absolute drug. So here, there are a couple of drugs which are not routinely used for epilepsy, like paradoxin. It's only for vitamin B6 responsive seizures, or prednisolone for like West syndrome, ACTH for West syndrome, or methylprednisolone for immune-mediated conditions, or IVIG in case of status epilepticus, which is drug resistant. So coming to one appropriate drug for one specific seizure type. So for example, focal seizures, it's carbamazepine followed by valproate sodium, or if not controlled, maybe levetiracetam. Here, I would like to say the side effect profile of these new anti-epileptic drugs is much superior as compared to the older drugs. However, one should always consider the cost and affordability or availability. These are the main crux of this slide: availability and affordability. I have seen in my experience prescription of the colleagues about phenobarbital, which is not easily available these days. For generalized seizures, it's valproate sodium lamotrigine. For absent seizure, valproate sodium, though classically in literature it's ethosuximide, but ethosuximide is neither available nor registered in Pakistan. So if valproate sodium is not successful, then lamotrigine. I would like to mention about tuberous sclerosis complex, which is one of the most common neurocutaneous syndrome in children and in infants. And the drug of choice for tuberous sclerosis is vagobatrin, which was initially not approved by FDA for quite some time, but was approved in many European countries. But recently, in the past almost 2.5 and 3 years, it was available as a registered drug in Pakistan. So one may consider this in case of West syndrome on tuberous sclerosis complex. There are many children which have intractable epilepsy, which may end up with the drop attack or nasal bone injury. So one should be very clear about children who have intractable epilepsy. By definition, it's 2 or more anti-epileptic drugs which are appropriately chosen according to the epilepsy syndrome. And if still seizures are not controlled in 3 months' time, maybe, then one should always label or consider them as intractable epilepsy. And one may switch to not only anti-epileptic drugs, but also to other treatment options, as I mentioned in my initial slides, like ketogenic diet or epilepsy surgery, etc. Like all drugs, definitely there are some side effects of anti-epileptic drugs. So one should always follow and look into the side effects of drug prescribed in that particular child. So gingival hyperplasia, drug rash, hair fall, obesity, teratogenicity, all these are the common side effects of many drugs, including valproate. Here I would like to mention about valproate, which has been given this red label warning by NHS, WHO, and many other agencies. And this red label was even now a compulsion by the Pakistani health authorities for the manufacturers of valproate to show on their packings, because recent data is not very supportive in terms of its teratogenic and behavioral effects in children and women of childbearing age. I'm sure already it has been discussed during the Professor Memuna's presentation as well. Apart from these side effects, valproate is also notorious for thrombocytopenia and rashes, and at times it is hair fall and change in the behavior as well. So I would like to emphasize about the education, because as I mentioned before, it's a drug, it's a disease for quite some time. For one has to take these drugs, anti-epileptic drugs, for a couple of years. So education of the family is really important. So we have developed these small booklets and treatment record books and follow-up record books and a seizure record book for parents and for their families. So proper guidance is hallmark of good epilepsy control and to reduce recurrence of seizure, breakthrough seizures. These are some of the newer modalities, like I mentioned, ketogenic diet and CBD oil. And we have actually developed this small booklet in our local language, Urdu, for the guidance of parents, because again, ketogenic diet is not actually very common in Pakistan for the management of epilepsy actually, but is being practiced for weight reduction in many aesthetic clinics. But we have actually for the past almost 3 years developed keto clinic in our department. So after a successful course of anti-epileptic drugs for 2 to 5 years, then the most important point for physician who is actually looking after is the discontinuation of anti-epileptic. So seizure-free 2 to 5 years, according to the patient, one may consider discontinuation, rather tapering of anti-epileptic drugs with a normal EEG. So this is really important. One should guide the parents, guide families about possibility of seizure while drugs are being tapered. So again, my emphasis is on guidance of the families. These are some of the future options for the youngsters. There are many anti-epileptic drugs which are at different phases of trials, phase 3 and onwards. Epilepsy surgery and stem cell transplantations are again under investigation. Neurostimulation. Actually, epilepsy surgery is being done in many centers in Pakistan and as well as globally. But stem cell, neurostimulation, gene therapy, these are under investigation things. I'm not sure whether DBS is really helpful for children with epilepsy, but it's again being practiced in some of the private centers, though very successful for movement disorders. I will not spend more time on VNS because our area of today's talk is anti-epileptic drugs, but again, VNS is a thing which is primarily for drug-resistant epilepsy. So I will conclude my presentation. Epilepsy is a commonest neurological problem, and misdiagnosis is quite common. So correct diagnosis, identification of correct syndrome is really hallmark of the good and successful treatment. So if one diagnose correctly, choose a correct appropriate anti-epileptic drug according to that index patient, then the possibility of success is quite high. And up to 70-75% patients are seizure-free after 2 to 5 years of use, appropriately chosen use of anti-epileptic drugs. So thank you very much. I will be happy to answer any question. Once again, thank you, organizer Dr. Malik, Professor Vase, for giving me this opportunity to speak on this very important topic on important day. Thank you very much.
Thank you very much, Dr. Tipu, for sparing time and giving this very, very important talk for all the even neurologists who deal the patient from on day-to-day basis. And this is a very important aspect to how when to start anti-epileptic drugs among the children, and they need to know what are the side effects and what are the things. So I really thankful. और जहाँ तक questions की बात है, we will take question at the end of the session.